産婦人科、脳神経外科、シスニ
Bismillahirrahmanirrahim. Assalamualaikum warahmatullahi wabarakatuh. Alhamdulillahillazi hadana li
Recording in
hadza
progress.
wa ma kunna linahtadiya laula an hadanallah. Asyhadu an la ilaha illallah wa asyhadu anna Muhammadar Rasulullah. Yang terhormat Dekan Fakultas Kedokteran Universitas Muhammadiyah Malang beserta jajarannya. Yang terhormat Associate Professor Dr. Mazuki Ishak, Medical Bachelor and Bachelor of Surgery, Master of Public Health and Doctor of Public Health. Yang terhormat Bapak Ibu dosen Fakultas Kedokteran Universitas Muhammadiyah Malang dan yang kami banggakan mahasiswa Fakultas Kedokteran Universitas Muhammadiyah Malang angkatan 2021. Puji syukur kehadirat Allah Subhanahu wa taala atas rahmat dan karunia-Nya kepada kita sehingga pada hari ini Rabu 23 Maret 2022 kita dapat hadir pada acara Guest Lecture Updates on Occupational Health during and after pandemic Covid-19. Dalam keadaan sehat walafiat. Tidak lupa juga salawat serta salam kita curahkan kepada Nabi kita, Nabi Muhammad SAW, yang telah membawa kita ke jalan yang terang. Demi kelancaran acara pada hari ini, marilah kita buka dengan bacaan Bismillah bersama-sama. Bismillahirrahmanirrahim. Berikutnya pembacaan ayat suci Al-Quran kepada Saudara Alexandra, kami persilakan.
Baik dokter, mohon maaf. A'udzu billahi minasyaitonir rajim. Bismillahirrahmanirrahim. Inna fi khalqis samawati wal ardi wa ikhtilafil laili wan nahar laayatin liulil albab. الذين يذكرون الله قياما وقعودا وعلى جنوبهم ويتفكرون في خلق السماوات والأرض ربنا ما خلقت هذا باطلا سبحانك فقنا عذاب النار ربنا إنك من تدخل النار فقد أخزيته وما للظالمين من أنصار ربنا إننا سمعنا مناديا ينادي للإيمان أن آمنوا بربكم فآمنا ربنا فاغفر لنا ذنوبنا وكفر عنا سيئاتنا وتوفنا مع الأبرار صدق الله العظيم.
Selanjutnya, sambutan Dekan Fakultas Kedokteran Universitas Muhammadiyah Malang atau yang mewakili. Yang terhormat, Dr. Ruby Tiana Asparini, spesialis bedah plastik rekonstruksi konsultan. Waktu dan layar kami persilakan.
Terima kasih. Bismillahirrahmanirrahim. Assalamualaikum warahmatullahi wabarakatuh. Yang terhormat tamu dalam acara guest lecture kita hari ini, Associate Professor Dr. Marzuki bin Ishak. Yang terhormat Dekanat FKUMM, dosen-dosen FKUMM, para panitia dan mahasiswa, anak-anakku yang tercinta. Alhamdulillah pagi ini kita berkesempatan mendengarkan lecture dari Profesor Dr. Marzuki bin Ishak yang merupakan dosen di Department of Social and Preventive Medicine, Faculty of Medicine, University Malaya. Beliau adalah faculty chairman dan bidang ilmu beliau telah terbukti dengan banyaknya publikasi terkait occupational health. Lecture beliau terkait occupational health sejalan dengan visi misi FKUMM sebagai wujud upaya FKUMM menghasilkan lulusan dokter yang berwawasan Islami dan mempunyai keunggulan dalam bidang kedokteran industri. FKUMM juga selalu melakukan monitoring dan evaluasi pelaksanaan integrasi kurikulum kedokteran industri. Dan upaya peningkatan keilmuan dan pemahaman dilakukan dengan melalui berbagai media, antara lain pembelajaran kedokteran industri tidak hanya dilakukan pada stase kedokteran industri selama 4 pekan, tapi juga terintegrasi pada stase-stase yang lain. Metode pembelajaran di profesi berupa tutorial klinik, manajemen kasus, bedside teaching, journal reading, dan refleksi kasus. Mapping pembelajaran kedokteran industri itu merupakan bentuk integrasi yang berupa status rekam medis, modul, dan e-logbook. Dan setelah lulus yudisium dokter dan sebelum UKMPPD, dokter muda wajib mengikuti uji kompetensi dengan skema dokter perusahaan yang diselenggarakan oleh LSP UMM. Nah, sertifikat kompetensi sebagai dokter perusahaan akan diberikan kepada dokter muda bersamaan dengan ijazah dokter sebagai surat keterangan pendamping ijazah. Semoga guest lecture kita memperoleh manfaat yang sebesar-besarnya dalam meningkatkan wawasan keilmuan dan pemahaman akan occupational health, sehingga nantinya dapat melahirkan karya-karya penelitian di bidang ini. Terima kasih. Assalamualaikum warahmatullahi wabarakatuh.
Waalaikumsalam warahmatullahi wabarakatuh. Baik, acara akan kami lanjutkan dengan pemaparan materi mengenai update on occupational health during and after pandemic COVID-19 yang akan disampaikan oleh Dr. Marzuki Ishak, Medical Bachelor and Bachelor of Surgery, Master of Public Health, Doctor of Public Health. Dengan moderator Dr. Rubayat Indradi, Master of Occupational Health. Waktu dan layar kami persilakan.
Baik, terima kasih Dr. Rahma. Suara saya sudah terdengar ya? Jelas ya?
Sampun dokter.
Ya, terima kasih atas kepercayaannya untuk saya ditunjuk menjadi moderator pada guest lecture kali ini. Assalamualaikum warahmatullahi wabarakatuh. Izinkan saya membacakan kurikulum vitae dari pemateri yang saya rasa cukup panjang ini ya. Nanti akan saya ringkas. Nama lengkap Dr. Marzuki Ishak, MBBS, MPH, Dr. PH. Sekarang beliau bekerja sebagai Occupational Health Physician and Health Advisor for Petronas, sebuah perusahaan minyak dan gas di Malaysia. Ya, saat ini beliau sebagai Public Health Physician with National Specialist Registry and Occupational Health Doctor, sudah menjalani pengalaman sepanjang 18 tahun saat ini posisi beliau sebagai Honorary Secretary of the Academy of Occupational and Environmental Medicine Malaysia. Kemudian beliau pengalaman juga sebagai Head of Department of Public Health and Occupational Safety, Health and Environment, UNMC. Sekarang sebagai Associate Professor in Occupational and Environmental Health in Department of Social and Preventive Medicine, Faculty of Medicine, University of Malaysia. Untuk riwayat pendidikan menempuh doktoral di University of Malaysia, Malaya 2013, Master of Public Health 2008, Occupational Health Doctor Certificate dari National Institute of Occupational Safety and Health 2007, Medical Bachelor and Bachelor of Surgery, University of Malaysia 2003. Riwayat pengalaman kerjanya cukup panjang untuk sebagai praktisi di bidang kesehatan kerja, kedokteran kerja. Kemudian beberapa publikasinya sangat banyak. Di antaranya yang terakhir adalah tentang implementation of COVID-19 surveillance program for healthcare workers in a teaching hospital in an upper middle income country. Kemudian pengalaman-pengalamannya mulai 2008 kalau tidak salah. Maaf 2001 ya. Baik, saya sapa dulu Prof. Marzuki. Assalamualaikum warahmatullahi wabarakatuh. Selamat pagi, Prof. Marzuki.
Waalaikumsalam, Dr. Rubaiyat. Selamat pagi.
Ya, bagaimana kabarnya, Prof? Sehat-sehat ya?
Alhamdulillah sehat.
Baik, alhamdulillah. Ya, jadi kita ingin mendengarkan pengalaman Prof. Marzuki selama mulai beberapa tahun ke belakang. Apalagi ini pada saat pandemi COVID ya, kita ingin memberikan pembelajaran kepada mahasiswa kami bahwa kedokteran okupasi ini atau occupational health ini apakah ada perannya, apakah ada pengaruhnya pada pandemi COVID-19 ini ya. Untuk Prof. Marzuki, untuk waktu nanti kami sediakan cukup panjang Prof, karena pembelajaran kami juga biasanya 1 kali tatap muka itu 100 menit ya, tapi ini kami berikan sedikit lebih panjang, nanti 90 menit ke depan Prof. Marzuki akan menyampaikan materi, kemudian nanti 15-20 menit setelah itu diskusi, tanya jawab dari adik-adik mahasiswa kami dan juga mungkin dari para dosen ya. Baik Prof, waktu dan layar kami serahkan kepada Prof. Marzuki. Untuk PowerPoint, saya bantu atau dari Prof. Marzuki?
Saya akan share sendiri.
Oh, baik.
Okey. Terima kasih Dr. Rubaiyat. Assalamualaikum warahmatullahi wabarakatuh. Selamat pagi semua. Very good morning everyone. Yang dihormati Bapak Dekan, Dr. Medi Setiawan, and then Wakil Dekan, Dr. Ruby Riana Asparini, and then MC juga, terima kasih Dr. Rahma. Okey, yang membaca doa tadi sangat sedap dan sangat merdu ya. Dan semua profesor, pensyarah-pensyarah, dosen-dosen dan juga pelajar-pelajar perubatan sekalian. Assalamualaikum warahmatullahi wabarakatuh dan selamat pagi semua. Pertamanya saya mengucapkan terima kasih kepada Universiti Muhammadiyah Malang kerana menjemput saya untuk memberikan guest lecture pada hari ini. It's a very much appreciated and I feel very honoured to be invited here. Okay, untuk drama pada hari ini, for today's lecture, I'll be delivering the lecture in English. I hope you all are fine with that. Is it okay? Alright. Okay. Okay, terima kasih Dr. Rubaiyat. Thank you very much for your very kind introduction. Okay. Alright. Thank you very much. So I'll be sharing my slide here. I hope I can fulfill whatever objective that's set by the organizer today. Okay, can I check whether you can see my slide? All right, thank you. Thank you very much. Okay, I feel very honored actually when Dr. Rubaiyat called me and then requested for me to deliver a lecture to Universiti Muhammadiyah Malang. This is the first time I'm in contact with Universitas Muhammadiyah Malang. Before this in Indonesia, I've been invited by Universitas Indonesia, UI. I given a lecture once there, and then University of in Yogyakarta. I can't remember the name of that university. And then I was invited by Trisakti University for a few times there to give their symposium, conference, plenary speakers. Basically, Indonesia University is very close to my heart. I do publish some journal article together with lecturer from Indonesia actually. Some are research conducted in Indonesia. We do some collaboration and publish a paper regards to ASEAN data, Southeast Asia data. So this collaboration still going on, especially from my colleague from Universitas Indonesia. As for today, I'll be sharing with all the students here, with the professors. I'm very much respect all the professors here in occupational health. I hope you all can share your knowledge as well, not myself alone. We can share each other. What is your experience in Indonesia in conducting COVID? You all have very much a lot of experience. And of course, with all these challenges that we've been facing for the last 2 years, we have learned a lot from the pandemic that we have experienced. Wherever you are, whether you are in Indonesia, in Malaysia, whether you're in Europe, in US, all of us are in the same learning process. Okay, so today I'll be sharing a little bit on briefly on occupational health, introduction to occupational health. Then we'll go through the pandemic itself, what will happen, what was happened during the pandemic, and what will be happening after we move into the endemic phase itself. Okay. A little bit about myself. Just now, Dr. Rubai has introduced myself. At the moment, I'm still the associate professor in Department of Social and Preventive Medicine, University of Malaya. But at the moment, I've been seconded for 2 years in Petronas. Petroleum Nasional Berhad in Malaysia is one of the big multinational oil and gas company in Malaysia. So this is my hospital, University Malaya Medical Center. This is where I work for the past 17 years as a lecturer there, and we practice occupational medicine in this hospital as well. So in this hospital, we receive cases related to occupational disease. So industry, this is in Kuala Lumpur. So industry surrounding the hospital, if the industrial doctor from there suspect of any occupational disease, they refer to us for further investigation and confirmation. So our master student will see the patient, and also we will set a visit to the workplace to investigate further whether that particular disease is due to work process or not. If it is, then we'll treat the patient, we'll assist the patient in terms of compensation. We have occupational disease compensation, and also advise the workplace on how to prevent other workers from getting the same disease. So kesihatan kerja ini sangat penting, very much important, because we not only treating the patient, we understand that clinician, they always treat the patient, right? But as of in occupational health, we also prevent the disease. That's why this occupational health is under the Department of Social and Preventive Medicine in University of Malaya. We not only prevent that one particular patient from, we not only treat one particular patient from occupational disease, but we also prevent other workers surrounding him from getting the same disease by preventing the exposure to the occupational hazards. Now I'm functioning as a specialist, occupational health specialist, occupational physician in group health, safety and environment in a corporate company. It is oil and gas company. The challenges is very high, very much hectic kind of work. My office is in level 21 here in Tower 1 of Kuala Lumpur Twin Tower. So managing corporate demand, not only we have to manage the corporate demand, but also we have 40,000 workers, 40,000 Petronas workers around the world. Not only in Malaysia, we have workers in Brazil, Canada, Egypt, in Cambodia, in Indonesia as well. We do have staff workers under Petronas. So the challenges is bigger. We have to set a policy For COVID-19, for example, what we need to do if there is an outbreak and so on, to ensure that everyone is worked safely in their workplace. So this is the real world of industrial doctor, of occupational health doctor. Besides then treating patient, we also have to give advice as an health advisor to the corporate industry company. Okay, as for today, I'll give an introduction to occupational health, and then we'll go through a trend of COVID-19 and what we can expect on the occupational health function during the pandemic and during the transition from pandemic to endemic and post-pandemic itself during the endemic phase. There's a lot to discuss here. I hope we can have a lot of two-way communication so that each of us can learn from each other. Some introduction on occupational health. Of course, all of you have gone through a syllabus of occupational health. I hope you all are well versed with occupational health here. From here, we can see maybe a student or a teenager playing with video games. Okay, and obviously he's exposed to some kind of ergonomic hazard here. Y'all, if you want to respond to any of my question here, y'all can just unmute yourself and just respond to the question. Okay, we can see here is one of the ergonomic hazard for students. Okay, but from here, this is an example of people working with a computer workstation as well. Computer screen. Workers are exposed to ergonomic hazard as well in the hospital, for example. Okay, and obviously the posture is not right. There's a bended knee here, and the computer screen is not at the same level of the eye level. They have to extend the neck a bit, and the mouse position is not at the optimal position here. So if you see the first slide and the second slide, both are exposed to ergonomic hazard. But it seems like this workstation seems to be more comfortable with a very nice chair, fluffy chair here again. But then we can see the difference between this occupational environment and home environment. Even though they are exposed themselves to ergonomic hazards, but the difference between these two photos, one is occupational environment and the other one is non-occupational environment. It's an optional. Okay, what we want to manage here is this occupational environment, how we want to reduce this occupational hazard at the workplace, so this doctor and nurses won't get any ergonomic related problem or musculoskeletal problem. Okay, injecting drugs. People injecting intravenous drugs is an option. They can get needle prick injury by injecting it. They can get biological hazard. They can get infection from injecting intravenous drug here. Okay, but a doctor who's taking the blood in the hospital, for example, they work as a nurse, they work as a doctor taking blood, and they expose themselves to this blood as well, to this biological sample. So they are at risk of getting any biological infection due to this work process. But this is occupational environment as compared to the earlier photo here, whereby this is an option. They choose themselves to injecting the drug. They can get the infection, for example, hepatitis B or HIV from here. But if the doctor prick themselves, they also might get those infections from this work procedure. Another example on psychosocial exposure. A housewife work at home, managing the house with all kids around, they expose themselves to domestic stress. Okay, as compared to those working in the office, they are exposing to psychosocial hazard as well, but the environment is different. One is workplace environment and the other one is home environment. Both can give same effect, but as an occupational health doctors, of course, we want to manage those who are exposed to occupational hazards. But now, what is the problem is when we have to work from home. When the pandemic comes, working from home is not easy. We are exposing ourselves to home work conflict or work home conflict, either one. So, as an occupational health physician or occupational health doctor, We always want to promote and maintain to the highest degree of physical, mental, and social well-being of the workers. The difference with other doctors, other type of specialty, we are looking into the health of the workers, mentally, physically, and also social well-being of the workers in all occupation by preventing departures from health. Workers coming healthily, we want to prevent them from depart from their healthy status, control the risk, and adaptation of work to people and people to their job. Of course, we want as far as possible to adapt whatever work that we are doing to the people, to the workers. So adapting them to whatever ergonomic position or anatomical position of the workers themselves. So this is the definition by ILO and WHO from 1950s. So in occupational health, we concern about the effect of work on health. There's a lot of effect on work on health. You can imagine you're exposed to physical, chemical, biological, psychosocial, and even ergonomic hazard. So all those hazards can give an effect to our health. But what is the effect of our health to our work? For example, if we down with a disease, we can't work. So our work will reduce in terms of the productivity itself. Okay, we might have a prolonged sickness absenteeism because of the health effect. So in occupational health practice, we not only treat the workers, we also treat the workplace. Whatever control measures that we do, we always look into these two aspects. So I think all of you might have seen this in terms of relationship in workers, workplace, and health. So whenever we expose, before you enter your workplace, we will do your pre-employment examination. All company, we want to make sure that we employ those are healthy workers. So you have to go for the pre-employment examination and your health status is good before you are entering the workplace. However, at the workplace, you might be exposed to a lot of hazard in this workplace. Okay, with the exposure for 30 years, 40 years, the function of occupational health is actually to prevent your health from deteriorating and make sure you are exiting or come out from the workplace when you are retired healthily without have any impact to the hazard that you are exposed at the workplace. You want to reduce the amount of hazard exposure. You want to reduce the use of the hazard itself so that you can come out healthily. Okay, you might come up with some latent disease or clinical disease, or people might come out earlier from when you have a premature death because of exposure or injury at this workplace. So these are the health outcomes that might occur whenever you're exposed to these hazards. So we want to prevent this death, clinical disease, occupational disease, and any latent disease due to exposure to this workplace. Okay, example of pregnant nurse. She's a pregnant nurse working in an operating theater. All right, what happened when a pregnant nurse works in the operating theater? Of course, in operating theater, you are exposing yourself to anesthetic gas, okay? And we know anesthetic gas has a risk of spontaneous abortion among those pregnant ladies. So if you're exposed to leakage of anesthetic gas itself, nitrous oxide from the anesthetic gas, there's an impact, there's a health effect of spontaneous abortion due to this exposure. However, with all the engineering control that we have, we make sure there's no leakage to the anesthetic gas, so that we can prevent this spontaneous abortion. But other administrative control that we can do by maybe we can have male nurse, or maybe we can have a non-pregnant nurse to work in the operating theater. However, besides than this administrative control, we might want to apply an engineering control also to make sure that there's no leakage. Make sure that the workers here will not be exposed themselves to nitrous oxide. So this is one of the examples of risk assessment that we have to do to ensure that the workers is fit to whatever job that they have to do. Another example of clinical disease here, this is dermatitis, okay? Can be irritant contact dermatitis, but from here it looks like an allergic contact dermatitis. So healthcare workers might get this allergic contact dermatitis due to exposure to the protein inside the latex glove itself. But those users of latex glove, they can get either irritant contact dermatitis or allergic contact dermatitis. If you got if they got a disease like this, allergic contact dermatitis, all the erythematous, redness, kemerah-merahan, and there's a swelling there, most probably due to the protein inside this latex glove itself. But if they have a dryish skin, scaly, most probably it is an irritant contact dermatitis due to the powder inside the glove itself. So with this kind of disease that presented to our occupational medicine clinic, we have to manage by giving treatment to this patient, to these workers. We might want to give a steroid to reduce the allergic reaction. We might want to give antihistamine to reduce the pruritus, all right? But then the disease will come again when the workers exposed to this latex glove. What we have to do? So you have to prevent the exposure. You have to give an alternative of using non-latex glove and non-powdered glove for this one particular workers maybe. Because not everyone will develop allergic contact dermatitis after exposure to latex glove. So that's among the occupational health services or advice that you can give. Okay, another example among occupational, clinical workers or healthcare workers whereby they can get tuberculosis. From this lung X-ray, obviously there's an opacity of the upper lobe of the lung, okay? Classical presentation for those with tuberculosis. So healthcare workers, they're at higher risk of getting occupational lung tuberculosis when they are treating the tuberculosis patient. Some patient coming with cough and everything, we might not know that they are having TB. And when we expose ourselves, we are at risk of getting occupational lung tuberculosis. So we do see this kind of cases in our clinic, whereby our healthcare workers expose themselves to tuberculosis patient and get infected with occupational lung tuberculosis. Okay, asbestos is another issue here, very important hazard here, whereby there's one type of asbestos, what we call as crocodylite asbestos. It's very malignant, which can cause lung cancer and also mesothelioma. So this is another good example of occupational disease, whereby workers can get mesothelioma if they expose themselves to asbestos. Okay, the asbestos fiber, very small asbestos fiber, can go deep inside your mesothelioma, and by time after 20 years, after 30 years, the asbestos fiber will stimulate the production of plaque formation in the pleura and also mesothelial cell and lead to the development of mesothelioma, which is a malignant cancer of the mesothelial peritoneal lung lining. Okay, that's the example of occupational disease that we might see in our clinical practice. As an occupational physician, okay, we not only do the prevention part, but we have to do the clinical part as well, whereby we sit in the occupational medicine clinic, treat patients and advise on how they want to prevent, how we can prevent the disease from happening again. I hope every one of you has been familiar with occupational hazard exposure. We have different types of occupational hazard. I'm sure everyone here is familiar with this. There's many types of hazards. How safe is our workplace? Whether every day we have to lift patient, we might have inappropriate posture. So this leads to exposure to ergonomic hazard, exposure to physical hazards, some kind of biological hazards, psychosocial hazards, and also chemical hazards. So all this will give an impact to our workers. Some of the example of biological hazard, just a revision to all the students here. Any bacterial, viral, fungus, mycobacterium, parasite, and blood-borne pathogen, all these are the example of biological hazard. And of course, the recent one is the SARS-CoV-2 virus, which can lead to COVID-19. Ergonomic hazard, even though we thought that those working in the high-rise building expose themselves to ergonomic hazard as a dangerous occupation, but this is also a dangerous occupation. You're working in front of the computer, typing, and actually a typical computer user, you walk several miles each day. You walk with your fingers when you are typing. So with this typing work nature also, you might get some kind of occupational musculoskeletal diseases. Some example of occupational musculoskeletal disease like rotator cuff tendinitis. If you have any orthopedic surgeon here, you might know, or we have to know that this involves these four type of muscle here, tendon in this area, our shoulder joint. So shoulder joint, there's 4 muscles whereby the tendon attached to almost the same location here. Supraspinatus, subscapularis, teres minor, and also infraspinatus. So this area lead to the very less vascular, hypovascular area. So if there are any injury, the recovery will be very slow. This is, the injury can occur when you, like for example, you lift the object above the shoulder level. So when you lift the object above the shoulder level, there'll be an impingement in this shoulder joint itself towards this acromyoclavicular joint. So whenever there's an injury, the shoulder will get inflamed and the recovery might take time. So this will lead to rotator cuff tendinitis. So if we have this kind of patient, we need to investigate whether the patient exposed to abduction, elevation, or whether they have any acromyspurs and so on. Another example, decoupling tendinosynovitis or decoupling disease, whereby if the workers involve rapid, repetitive, and forced movement of the thumb, sometimes they need to press something using their thumb. So if the patient coming with the decoupling tendinosynovitis, our doctors usually will go to the workplace and see whether they involve into a lot of this activity involving thumb or compression on the thumb. We can simply confirm it by doing the Finkelstein's test by grasping the end of the thumb itself, distal end of the proximal thumb, distal end, and do like this flexion. And then if you have pain at the base of the thumb, meaning there's some form of decoupling tendinosynovitis there. Beside the musculoskeletal, some example of psychosocial hazards. Okay, now we are working in the pandemic era, whereby everyone is, some of us might work at home, and there's no border between home and work, and some of the job demand might increase as well, including the emotional demand and also psychological demand, not only the physical demand only. So if there's increase in physical demand, emotional demand, and psychological demand, in addition to bullying and harassment, this might lead to the psychological health outcome, like psychological distress, exhaustion, and also depression. But if we have enough control, we have enough support from the supervisor and our organization coming out with a very good rewards to the workers, this will lead to higher work engagement, increase in job satisfaction, and reduce the intention to leave the work itself. So this some kind of health erosion pathway, motivational pathway for psychosocial hazards. Another brief example for chemical hazards. These are different types of chemicals used especially in the hospital, and each of these chemicals might have some effect to our health, whereby glutaraldehyde, chlorhexidine for cleaning just now is that used for disinfection of instrument, associated with the presence of asthma. The ethylene oxide that used for cold sterilizing agent is associated with pulmonary edema or allergic asthma. Aqueous solution that we use containing formaldehyde also is important as mentioned. Some chemical in the lab, xylene and toluene, if you use together, it can increase the risk of us getting Raynaud phenomenon. Raynaud phenomenon is a vasoconstriction of the peripheral fingers, of our fingers. Exposure to organophosphate poisoning among our vector control when killing mosquito among our foggers. This can lead to Parkinson-like syndrome if you're exposed to organophosphate poisoning. Like for example, as an example I give earlier on nitrous oxide, they can lead to a spontaneous abortion. Carbon sulfide used in the lab can reduce the sperm quality of the handlers, and methotrexate drug can lead to infertility, miscarriage, and low birth weight. This is the example of Raynaud phenomenon, whereby one of our lab workers exposed to both xylene and toluene without the use of the glove itself, and this exposure lead to Raynaud phenomenon. We can see this we can call as white finger disease as well, white finger syndrome, whereby all the fingers become white due to vasoconstriction of the peripheral vessels. It almost has similar effect if you expose yourself to vibration as well. One time I did a research on vibration, whereby our workers who are involved in logging activity, cutting the trees, they also have higher risk of getting Raynaud phenomenon because they expose themselves to hand-arm vibration. And last one is physical hazard, whereby we can expose ourselves to high or low temperature, ionizing or non-ionizing radiation, illumination, not enough lighting when working, vibration that I mentioned just now, and noise. Noise also is among an important exposure hazard. When I'm working with oil and gas company, actually many of our workers exposed to noise hazards. And it's quite challenging as well when we want to manage it, because even though all the control measures that we have applied, we still receive notification or cases of noise-induced hearing loss. People still experience this hearing loss due to exposure to noise more than 85 decibel for 8 hours. So we need to improve further in terms of our control measures, improve the behavior itself of wearing the PPE. Okay, that's the example of hazards as an introduction to occupational health. So are we at risk or not? Are we at risk? Yes, of course we are at risk. Because in our daily work, regardless whether you are working in the office, you are working in the construction site, we are exposed ourselves to hazards. When there is an hazard and you expose to that hazard, then there is a risk. What we can do to reduce the risk is either reduce the hazard, take out the hazard, eliminate the hazard, or substitute the hazard from the severe one to the less severe hazard, or we manage the exposure. How we can manage the exposure? By having engineering control, by having administrative control, or by wearing a personal protective equipment or PPE. I hope all the students here has understand that on hierarchy of control measures, right? Okay, whereby we can eliminate, substitute, do the engineering control, administrative control, and also apply a PPE. PPE is the least because PPE is only protect the individual, not protecting others. If one person didn't wear a PPE, that person can get the disease. But if we eliminate and substitute, we're taking care of the group of workers in that particular workplace. That's why eliminate and substitution is at the higher hierarchy of control measures. After we understand the basic of occupational health, we see what is our current global burden for safety and health. We see, yes, of course, there's a lot of people, 2.7 million workers die each year due to occupational disease. Workplace, and 2.4 million dying due to occupational disease. And up to 380,000 workers die due to occupational injuries. See, occupational disease is much, much higher as compared to occupational injury. But if we are in the industry, we see when people die from falling from height, they die, it's a big news. But people die because of occupational cancer, nobody talk about that. Okay, but actually there are more people die from occupational disease as compared to occupational injury. Okay, 86% died due to occupational disease, as compared only 14% died from occupational accident. This is our safety engineers. They prevent occupational accident. But this is the role of our occupational doctor, to prevent occupational disease. But this is not reflected because there's a lot more actually. Not only occupational disease due to exposure to hazard in the workplace, some workers exposed to environmental impact. For example, if they have silicosis from exposure to silica, and they have exposed to tuberculosis as well, the impact will be much, much bigger. Another example is they're having asbestosis and they are smoking as well. The impact is much, much higher. Okay, so another the statistic will be much in the growing trend, because there's a blurred line between workplace, home, and community now. People are exposed in the family, especially those young and vulnerable members. People are working from home, and people are exposed to hazard at home itself and in the community as well. People can get COVID from community and bring it to the workplace. People can get COVID from the workplace and bring to their family members. So this blurred line has led to higher growing trend to occupational disease. And then workers in the developing economies who are not employed in formal section, those working for Grab food, for example, they are riding the motorcycle dangerously sometimes, but they are not covered under the social, maybe occupational provident act, whereby if they are having accident, it is not covered because they are in informal section. Those taking care of the roadside. When I go to I went to Indonesia last time, there's a lot of helpers who are taking care of the traffic, right? So these people are informal workers. What happens if they have any accident? It might not be reported. So the statistic will be much higher if it involves all these informal workers. And then a scarce of medical facility and treatment in the emerging economy, in the emerging economic country, there might be have a scarce in medical facility and a non-existent public health registry for major illness. Occupational disease, yes, currently we have to notify to the authority, but not everyone actually notifying the occupational disease, and we didn't get an actual data there. And the reality that while filter illness outnumber the injury is still the thing that studied in detail. You imagine when people trap their hand inside the machine and got amputated, they will do a detailed investigation of that incident. But what happened if a lady get carpal tunnel syndrome? Nobody will care about that because it's not pretty obvious. We will not do the proper investigation. So more attention being given to occupational injury as compared to illness. We have to be the other way around because illness is more than injury. This is a global compensation. We can see most of the compensation come from musculoskeletal disease, mental disorders, cardiovascular, central nervous system, respiratory, and only a portion of it is accident. Okay, so these global risks, emerging global risks like complex technology, new form of work organization, whereby work become more intense now, working time arrangement, people work with those in other countries have to arrange their time, fragmentation of the production process and organizational restructuring. All this gives to a more stress to the workers. An emerging form of employment whereby there's a lot of home-based work, part-time work, all this also lead to the emerging global risks. Higher job insecurity, higher job demand, precarious employment, and also there's a lot of political changes. Even though during COVID time, there's a lot of election going on, increased risk. So all this lead to increase in terms of emerging global risks. And we as an occupational health doctor have to play a role on how to overcome all these emerging global risks. Okay, that's all for the introduction of occupational health. I hope all the students here has an ideas on what is our functions as occupational health physician or occupational health doctor. We have to play our role actively so that our function will become our profession very much rationalized, and our demand, I can tell you our demand in the industry is very high. People see the importance of having occupational health doctor in the company. Okay, and of course they are highly paid as well. Not only for those clinicians, surgeons working in the hospital, occupational health doctors in the industry, they are very much needed to make sure that all the workers are safe and healthy. Okay. All right, looking into COVID-19. So it's the time now, it's 9:50, okay. Looking into COVID-19, this is another challenges that we face in the industry, not only in the population, but also in the industry. Why in the industry? Because we receive a lot of impact from this infection. We have to close our factory. We have to close, reduce our capacity. Of course, it gives a big impact. One person having COVID, another 3% might be close contact. We have to quarantine them. So obviously, this reduces the productivity of the company. So this COVID-19 itself increase the need or the function of occupational health doctors. We as a public health physician and also occupational health doctors need to play a role in managing COVID-19, not only in the hospital, but also at the workplace. It's one of the most serious public health crises in modern human history, with more than nearly 500 million confirmed cases now and over 6 million deaths globally within the time span of more than 2 years already. We can imagine we have gone through this for past 2 years. How resilient we are now. Since 2000, early 2020 until now, I'm sure everyone has learned a lot and become more and more resilient. It is important for specialists and researchers in public health, environmental health, and occupational health to investigate the local, national, and global response to COVID-19 pandemic and drive the lesson for future preparedness and respond to the outbreak at the CLC. So next time, if anything like this happens, we are well prepared. We learn from whatever experience that we have gone through before this. Okay. At the moment in Petronas as well, I'm revising our pandemic preparedness guideline or standards so that we are well prepared. Petronas has been announced as the best company managing COVID in Malaysia, actually. It was announced end of last year, saying that in Petronas, we have a very good control measures and good governance, taking care of all the 47,000 workers in the company. So we received that for Malaysia. And the pandemic has brought to light now ever that the need of office service to act as a bridge between health and workplaces. Most of the doctors working in the hospital or frontliner in the community health, but in the company, in the industry, occupational health services, occupational doctors bring the bridge link between health and the workplace. I'm giving the COVID trend in Malaysia. You can see here, when the numbers are stagnant for quite period of time, it increased small outbreak, but during the Delta variant, it was increased up to 20 to 22,000 per day. Okay, but now this is early last month, whereby when the Omicron wave coming in, the numbers is increasing. This is during the pandemic itself. Okay, I'll show you the latest data after this, whereby what is happening now, have we reached the peak of the Omicron wave or not? Okay, from here we can see the active case per million is 4,000. even though the number of cases per day is not that high, but active case per million is 4,000 plus, meaning how many of our workers are impacted with this COVID-19. If we say that Omicron wave is much less severe, but our management, we have to change accordingly. We cannot be quarantining everyone who are close contact. This will damage our function in the company. So we need to do a proper risk assessment. With the case fatality rate now reduced to 0.07%, it's much lower. It's almost similar with influenza case fatality rate already. Okay, our positivity rate now up to 8.6%. So every 100 people, 8 people will be positive. And most of the cases are sporadic cases. It's no more on the workplace cluster or community cluster. Most of it has no history of contact, meaning that COVID is already in the community. Most of it coming from sporadic cases. As I mentioned, the case fatality rate has reduced to 0.07%. It shows that our colleague in the respiratory physician or internal medicine specialists, they have done their good work in terms of managing those patients. So less severe cases, less mortality. So public health colleagues also have done a very good work in terms of vaccination, in terms of control measures, making sure that the workers, the population are being vaccinated and prevented with less severe condition of COVID-19. This is in terms of COVID-19 vaccination tracking in Malaysia, whereby nearly 80% of our population has been vaccinated. This is total population, including those younger population, because now we have given those who are 5 years and above with the vaccine. And at the moment, nearly 60% of our population, 50-something percent of the population have received booster dose vaccination. Okay, what is our role during this pandemic? We have understand the pattern of the COVID-19 itself, how the trend look like, but during the pandemic, how we can function ourselves as an occupational health doctor. When WHO announced that the world is facing with COVID-19 pandemic, they announced the pandemic phase itself. It is important for us. At that time, I'm still in University Malaya Medical Center. I'm heading the public health department at that time in UMMC. So we have to make sure that we protect our healthcare workers. It's one of the big priority in response to COVID-19 outbreak. We want to make sure that our healthcare facility does not damaged or affected with this COVID-19. So occupational health service in the healthcare facility have an important role for protecting health workers and ensuring business continuity in the hospital. We cannot close the hospital. We need to be strong. I remember I'm giving talk to one of the big chain hospital in Indonesia as well. I can't remember the name of that big chain hospital. We discussed on how to manage occupational health in the hospital. It's a private hospital in Indonesia, whereby we advise them on how to do, to give occupational health service to protect their workers from getting COVID-19. So our department has come up with the Bilik Gerakan or COVID-19 management, one-stop center, okay, whereby in this operation room, we make sure that our healthcare workers are safe by rapidly identify, follow up, and closely monitor of healthcare workers who are in contact with COVID patient, do the risk assessment, manage them, monitor their symptoms, and investigate for any outbreak in the hospital. This is starting from February 2020 itself. We're coming up with this operation room. So there's 5 main divisions in that operation room during the start of the pandemic itself. So as an occupational health physician, we have to play our role together with the public health physician. We are a public health physician anyway. So we have to do contact tracing, risk assessment, surveillance, outbreak management, and also vaccination. So any workers who are exposed to COVID-19 patient, we will do the contact tracing. If there is a COVID case in hospital, we do contact tracing, and everyone who are in contact, we do the risk assessment. This is earlier on, whereby a risk assessment have to be done manually, and those who are considered as close contact, we will quarantine them and do the daily surveillance, asking whether they're having symptom or not, and do the management in terms of testing and quarantine. There's a lot of issues and challenges when we started all these things in terms of resource management, in terms of we have to come up with the infrastructure, people to work on that, and also financial management. And then multiple stakeholders involvement to develop the guideline. Not only public health people, we have to involve all the clinicians, pediatrician, infection control, respiratory physician, management up there to provide support and everything. We have to manage anxiety among our healthcare workers because they're exposed to the hazard. We have to make sure that the data is confidential and data management is well taken care of for future analysis and sustain whatever function that we have. That's why earlier on last year, we have this e-risk assessment and e-surveillance system, whereby everyone who are exposed to COVID patient, they have to go to this system, whereby in this system, they just click on the risk assessment. On the risk assessment, then they'll answer all these questions. Before we coming out with this algorithm, we have to call one by one, asking whether they are wearing masks or not, how far is their exposure like, and how long. So with this automation, they can do the assessment themselves, and then we can categorize themselves whether they are high risk, medium risk, or low risk, whether they have symptom or no symptom. So whenever they can get those risk level, they can get their risk management straight away. How many days they need to be quarantined, when they need to be swabbed, and all that. So this is earlier on when we started the COVID management in the hospital early last year. So as a occupational health doctor, we can see the list of workers who have done the assessment and whether they are high risk, low risk, how does it impacted our hospital function. And every day they have to answer whether they have symptomatic or not. So these are the systems that we developed in our hospital at that time to make sure that all this can be done automatically without the need of many people to call each one of the close contact. That one is in terms of management of the COVID itself, management of the healthcare workers. But as a practitioner, we work in the occupational medicine clinic. Now we have to stop the appointment of all patients that come to, and the less critical patient coming to our clinic. But then our patient, maybe if they have silicosis or asbestos or lung fibrosis, those with this disease, if they're contracted with COVID, the severity will be much, much higher. Okay, so former workers with occupational lung disease, they are at increased risk of contracting the disease. And potentially due to immunocompromise, their state of health due to COVID will be much, much worsened. So they need to be well informed about the precaution and resources to protect their health. So our patient with occupational lung disease, we inform them, make sure they take care of their health, make sure they're not exposed to this COVID-19 because the impact might be much, much higher. And then the real concern is among those who are dealing with lung cancer. All our patients with lung cancer, we inform them, make sure they take care of their own health. Don't go out and expose themselves to this COVID-19 virus at the time, SARS-CoV-2 virus, because of the impact of the disease itself might be more severe among them. Okay, this is an example of those with pulmonary fibrosis post-COVID-19. After, this is in April, and 6 months apart, we can see there's a little bit of scarring. Those with pulmonary fibrosis, development of COVID-19, they can develop pulmonary fibrosis as well post-COVID. This is one of the long COVID symptoms, whereby there's a scarring inside the lung itself due to COVID infection. So you can imagine if they got high fibrosis, and after that, if they work, they expose themselves to silica or to asbestos, this will make their condition much, much worse. And of course, we still have to do medical surveillance. Our our workers exposed to dust, we have to do spirometric testing every year. But this test can't be performed because it's exposed our staff to the risk of spreading the SARS-CoV-2 virus. So spirometry is a commonly performed assessment for lung function. So this one we need to stop for a while because of the risk of the spirometry assessment itself. So post-pandemic, we have to make sure that we manage these workers. During the pandemic, we manage the workers, not depending on the spirometry assessment, but we have to do our clinical judgment, clinical assessment itself. Okay, that is during the pandemic. There's a lot of challenges that we are facing. But now we are in the transition from pandemic to endemic. If you are aware, in Malaysia, the Prime Minister just announced that starting from 1st April, we are going towards the transition phase. We are not in endemic yet, but we are going towards transition phase from pandemic to endemic, starting from 1st April. So what is this transition of pandemic to pandemic? We understand the epidemiological triad here: the patient, the virus, agent itself, the host, and the environment. So how we want to limit the impact of the virus to the host with the support from the public health measures and medical advance here. Okay. We understand in pandemic, even though there is still a disease there, the virus still there, but there's a non-destructive presence of the virus. We can't eliminate the virus at the moment, but the presence of the virus itself is non-destructive, does not impact our quality of life, does not impact our functions. It will still exist, but at the predictable level. Maybe in the community, there'll be few new cases, maybe 5,000, 10,000 per day, but it is within the predictable level. Okay, once of the time, it can increase a bit, but reduce back to the predictable level. This is what we call as epidemic within the endemic, or outbreak within the endemic. It's just like dengue fever. There's a dengue fever in our community. It go back a bit during the outbreak and it come down within the predictable level. So even as the virus continue to circulate, number of cases are decoupled from severe disease, for example, like hospitalization and death, and also economic impact. Okay, walaupun even though we see there's increased number of cases, like last time during the Delta variant, cases increase, death also increase. But this time, it already decoupled with death. Even though case increase, the death still maintained at a lower level. This is what we call as decoupling effect between number of cases and burden of the severe disease itself. Because of that, we don't want our economic to be impacted with high number of cases as well. Because the burden, the severity is much, much lower. We don't want this high number of cases impacted our economy. So the government or the global decision to decide whether we want to live with the COVID-19 itself, whether the endemic phase only can be announced by World Health Organization. So as a country, we can get ready on the transition to the endemic itself. We are still facing the Omicron wave at the moment. Okay, we just completed our Delta variant wave, even though there's still Delta variants here and there, but most of the cases now is an Omicron variant wave, whereby we understand the wave is much, much steeper, is much, much higher in terms of numbers, transmission is much, much easier, but the severity from what we have seen is much, much less severe. The wave started abruptly and exponentially increased in terms of number of cases. And then the disease severity is lower and higher burden from the intervention compared to the disease itself. Why I say the higher cost burden? Because even we still do the same management. Those with the disease, we still take them out from the community, isolate them. They cannot go to the work. But actually the impact of the disease itself is not that much. They can just be symptomatic, but they tested positive kan, dia tak ada symptom pun. Tapi we still have to isolate them. So this gives a higher cost burden because the intervention that we do for that particular disease. And of course, there will be increase in terms of population get infected with Omicron variant. So there will be higher natural acquired immunity. So what we want to do when we see higher number of population get infected, more people will get natural immunity, and more people has already been vaccinated, and the impact of the disease now is much lower. So we have to start deprioritize COVID-19 now. We have to prioritize back whatever things that we have left for 2 years already. All the other important disease, tuberculosis, dengue, malaria, that one gives more mortality now. So despite, of course, we don't want to put away COVID-19 totally, we still have to manage them, but we have to start looking into other endemic disease, other diseases that affect our life. Okay, this is just showing the Omicron variant, whereby the wave is increasing in Asia as well. Malaysia been having 800 plus cases per 1,000 population. Over here, Indonesia having about 73 cases per 1,000 per 1 million population, because Indonesia has a higher number of population. So number of cases, the incidence rate is much lower. Okay, this is where Malaysia stays, whereby we have reached, at the moment we have reached the peak of the Omicron variants, starting to show there's a reduction in terms of the daily cases now. So our daily cases has reduced for the past 1 week. So we predict that this will continue to reduce up to the new baseline. We yet to receive a new baseline. So when we reach this new baseline, we consider that it will stabilize for a longer period of time. This is the decoupling effect that I mentioned just now. Even though the higher number of cases, okay, but patient in ICU not increase as what number of cases increase. As compared to Delta variant, when the cases increase, number of ICU patient and death is increased. But during the Omicron variants, even though number of cases high, number of ICU admission and death did not follow the number of cases. So this is what we call as decoupling effect. In terms of our resilience, Bloomberg resilience score, they look into in terms of percentage of vaccine, the lockdown severity, and then the flight capacity to ensure that the economy is running, to show whether our country is resilient enough to COVID-19 now. So in Malaysia, we have improved a little bit here to number 19, especially contributed to high percentage of vaccination, person who are vaccinated. Our border will be reopening starting from 1st of April to all the countries. So when we are going to a transition to a pandemic, a lot of standard operating procedure will be reduced now. As for Indonesia, also has improved a lot. Now it's number 44. Okay, especially with regards to the Indonesia still need to be improved, especially on the vaccination coverage and also the impact of the lockdown itself. We have to open up our economy now to make sure the impact of COVID-19 will be much lesser, and our population will become more resilient towards the pandemic itself. Okay, why will COVID-19 persist? Why we can't eliminate COVID-19? It's still in the endemicity. Even though we have vaccinated our population, but the immunity will wane down by time. A new variant might come. After Omicron, we don't know what kind of Decoupling, what kind of Megatron variant will come after this. We're not sure, kan? So when we talk about endemic, we're not only describing the disease transmission. It's not only signify the end of the global pandemic, but we want to see whether we are able to normalize our life or not by reprioritizing the health threats, other health threats that giving more important health impact. So this is the impact of the vaccination itself. I hope I still have time. Okay, 10:30, Dr. Bayat? Yeah, okay.
We have around 15 to 20 minutes more.
All right, thank you. So we can see here the waning immunity, the effect of the immunity from the vaccination itself reduced by time. After 150 weeks, the vaccine effectiveness actually reducing. So we might still have challenges. We will not be able to eliminate the disease totally because of this effect itself, waning of the immunity and also the variant that the new variant that comes in. Okay, this one is in terms against the infection, protection against the infection, and protection against the severe infection according to different type of vaccine. So actually our protection is reducing, but then the variant that coming in hopefully will be much less severe as compared to the previous one. Okay. You can see here in terms of percentage of vaccine effectiveness, when we are fighting with Delta variant, it can go up to 94% or 69% for infection. But when it goes to Omicron variant, it does give some protection, but the percentage has reduced a bit. Probably because of the waning of the vaccine effectiveness itself, or because of the characteristic of the Omicron variant itself. So over here, we can see the percentage has reduced to all types of vaccine in terms of protection against severe disease. Post-pandemic, we can see a lot in the next new normal, the emerging of stronger, we are emerging stronger as a host, as a human being from this coronavirus pandemic. We can become more agile, we can become more resilient. Starting from 2020, when we declared the pandemic, there's a lot of restriction being put in place. Okay. At first we thought, okay, movement restriction, everyone at home for 2 weeks, no more cases, and we stopped the pandemic. No, we can't do that. Life still have to function, hospital need to function, all the essential services, so transmission of these infections still occurring. We have all the movement restriction, lockdown, and everyone need to work from home. Borders all closed in 2020. I still remember the last time I visited Indonesia was in March 2020. I'm giving a lecture in one of conference in Trisakti University in Jakarta. After I come back, 1 month later, the country closed. Everyone cannot go out already. That's the last time I went to Indonesia. At that time, there's no single case of COVID in Indonesia yet. We were discussing whether those people attending the conference were asking, Doctor, is it true that Indonesia doesn't have any case until March 2020 at that time? I can't answer that. At that time, Malaysia already have a few cases, of course, but they were asking me whether there is cases in Indonesia or not. Okay, but all that is related to detection and testing that we are doing at that time and so on. And border testing, everyone has to go for PCR testing at a time. Hospitalization cases are increased. Everyone with the disease, regardless category 1, 2, 3, 4, or 5, everyone needs to be admitted to the hospital. Some people admitted without any symptom. I still remember those admitted, they have to be admitted for 1 month or 2 months until their result become negative, which is ridiculous at the time. We're still understanding ourselves on the disease itself. We have to do contact tracing, quarantine, mandatory face mask, physical distancing, and all the control public health measures. After 1 year, we have learned a lot, and we have applied. We try to open up our business. We try to open up our economy. At a certain period of time, when the cases reduce, the borders start to reopening, limited reopening, and self-test has come into picture together with the vaccination. This is a very important milestone, whereby there's a vaccination starting from, I think, early 2021. I received my first dose in March 2021 that time, and second dose 3 weeks later. And at that time, we feel more confident and in managing our pandemic at that time. Okay, but after we entering 2020, as far as possible, we try to start our normal life again. We try to go to the transition to the pandemic by having hybrid working environment. Maybe we used to have work at home for 2 years, those working in the office. Okay, only essential workers going to the workplace. But then hybrid working environment looks very much efficient. At first, we are scared to work at home, but now everyone are confident or comfortable working at home. In Petronas, when we're asking people to come back to work, they are very anxious. They are very scared. They are like going to the wall. They feel like, because they are comfortable working at home. Last time when we asked them to work from home, they feel the same anxious. They said they can't be working from home, children are disturbing them and all that, but now they don't want to go to the office, okay? In terms of risk assessment, we have to loose down a bit in terms of managing the event and traveling to the international borders, reopening of the borders, testing, we are depending more on the self-test, hospitalization only for severe cases, no need to hospitalize everyone, less severe home quarantine, isolation of positive case shorter. Previously, we isolate for 14 days, reduced to 10 days, reduced to 7 days now. Now in Malaysia, if you are positive, you need to be isolated for 7 days if you are completed, fully vaccinated. If you are close contact, previously close contact, quarantine for 14 days. We reduced to 10 days, reduced to 7 days. Now we reduce to 5 days only if you are symptomatic. If you have no symptom, no need to be quarantined, even though you are close contact. Face mask still mandatory, physical distancing is encouraged, all public measures, and we encourage for booster vaccination for all our population. So we need to have this in 2020 for our economy to function well and for our country to become more resilient. If we say that the COVID-19 become less severe now, this need to be aligned with the case management. Because if case management did not align with whatever control measures that we reduce, we still need to quarantine people with positive case for 14 days. We cannot afford to lose 14 days of productivity. So case management need to be aligned with the loosening of the control measures. Close contact, if you are asymptomatic, you can go to the workplace, no problem, provided you wear your mask. Okay. If you are symptomatic, stay at home, but just for 5 days. After that, the disease, if you have the disease, not be infectious anymore. And towards the endemic, we have not gone to the endemic yet. We are in the transition. When the WHO announced the pandemic stand down, hybrid working or normal working hours might still continue. People might still work hybrid. Borders will start to open and international travel will start. We expect there's an increased number of cases, of course, but It'll become of course, the disease will less severe, and the impact to the person itself will be much lower. It depends a lot on the self-test. Hospitalized only severe case, continue to cover for booster vaccination. We're not sure yet whether we need to have another booster or not, but depends on the waning of the immunity and the importance of the disease itself. So we need to have definitive COVID-19 treatment. That is during the pandemic. All this that I've listed here is the function of as an occupational health doctor in the industry. So in the industry, we have to manage all these things. During the pandemic, differently. During the endemic, differently. So these are the advice that we need to give to our company to ensure that our company or our industry can have a business continuity. If not, the economy will be disrupted. With that, thank you very much. I hope you're still awake, not sleeping. I'm so sorry for taking a longer time, all right? And I'm happy to have a discussion. I'm happy to have a sharing session with all the respected specialists, professors, and students here. Thank you very much. Assalamualaikum warahmatullahi wabarakatuh.
Waalaikumsalam warahmatullahi wabarakatuh. Thank you for the lecture and also sharing your experience during the pandemic. It's quite interesting, and also I think it's quite challenging as occupational health doctor, especially in Petronas, ya, Prof. One question from me before this is discussion time for the student. How we manage our time as your experience as occupational health doctor in Petronas, especially for the conduct the vaccination. I mean, I believe in Petronas we have you have maybe thousands worker, and how you manage for the vaccination, especially for the booster and so on, and how maybe you can share your experience for the vaccination.
Thank you very much, Dr. Rubaiyat. Very valid question. That's one of the challenges that we faced earlier on when the government said that everyone needs to be vaccinated. We quickly asked whether we can get the prioritization or not. Government said only for healthcare workers first. But we think that our manufacturing workers, our oil and gas companies, also important. We have to, essential workers still have to go to the plant. So after we have completed the healthcare workers, we quickly coming out with a Pusat Pemberian Vaksin for Industry. We call it PPVIN, whereby we collaborate with the government. We open up a big center for our vaccination center for the industry. So Petronas is the first industry in Malaysia coming out with our own vaccination center. So in each our plant, for example, in Sabah, Sarawak, in southern region, northern region of Peninsular Malaysia, we open up a big vaccination center just for our staff at that time. We collaborate with private vaccination provider. Okay. Alhamdulillah, we have no problem with the financial resource. Okay. Our management is very supportive with coming out with the financial resource in terms of assisting country to promote vaccination. So we put it as mandatory for all our workers before entering the workplace. They have to be fully vaccinated. If they are not fully vaccinated, they can't enter the workplace. This is under Occupational Safety and Health Act, whereby we want to ensure everyone is safe and healthy in the workplace. So to make sure that you're safe and healthy, you need to be fully vaccinated. We didn't say that, yeah, you have to be vaccinated. But what we say politically, if you want to enter the workplace, you have to be fully vaccinated. So if you are essential workers, you need to be fully vaccinated. You need to go into the workplace, then you need to be fully vaccinated. Okay. So these are the challenges that we face. But teamwork is very important. Sorry, Dr. Rubaiyat. Teamwork is very important, and support from the top management is very much important, and of course financial support, because this is not the, it's a collaboration between government and the private entities.
Is there also including the families for the wife or the children? Is there also included in this program in Petronas?
Yes, all of our initiatives involving family members. So when they come for the vaccination, they can bring their spouse for vaccination as well. If they got admitted for COVID-19, their wife also, their children also will benefit from the same benefit as for the workers. And not only that, we are helping the surrounding population in the plant itself. If they have difficulty of getting vaccine, they can come to our vaccination center for vaccination. Okay, so teamwork is very important. During that time, our task force involved up to 50 people in the meeting itself. We are planning for all this vaccination center. We have our doctor going to the platform in the middle of the sea itself. They went there and give the vaccination to all our workers in the platform itself. So that kind of outreach is important to make sure enough coverage for all the workers.
Okay, thank you, Prof. Now we have around maybe 20 to 30 minutes. We have some question from the student. Please, maybe the students, you can raise your hand by clicking the reaction, raise hand, and then you introduce yourself, your name, and what is your questions. Okay, please, maybe we have a question from the student. Okay, Jessica Luki, please unmute your audio, and then you have to introduce and please ask your question.
Okay, so thank you for the opportunity, Doctor. So my name is Jessica Luki, and I have a question for you. So my question is, based on the previous doctor's explanation, developing countries have like 70% of informal industries that may not implement an occupational health management system properly. How can we as students and doctors help promote and prevent occupational diseases for informal workers effectively? So that's my question, Doc. Thank you.
Thank you very much. That's a very good question. These are the cluster of workers that have been underprivileged, that not been looked into, because they are, we call it as a gig workers sometimes. These are the those working with a Grab company, for example. They're just driving by their own, sending food. Those working in the agriculture without having any employer, and then who's taking care of the traffic and so on. These are the people that need to be looked into, because most of the time they're exposed to more hazard than the formal workers. So what happened now in Malaysia, for the compensation, any gig workers, they can open up their own account. They can open up their own account and they can register themselves under what we call SOCSO in Malaysia, it's a social protection organization, a social security organization, whereby they will be considered as formal workers whenever they registered themselves into this SOCSO. So when they're registered, their well-being will be taken care of. There will be some contribution, small contribution they need to pay, because it's like a social insurance, okay? But whenever they have occupational exposure, occupational disease, they have occupational injury, this social security organization will take care in terms of compensation. That's one thing. Second thing, now we recognize informal workers as formal workers under the Department of Occupational and Safety and Health. So if they have any problem related to their work, they can report themselves to our labor office, no problem. Okay, as part of the community, we have to take care of all these informal workers as well. So we do receive some notification from informal workers, like Grab rider. When they are riding, they expose themselves to injury, they're exposed to vibration. So these people, they will be registered under the labor office itself. So we have to recognize these workers because they're exposed to significant level of hazards. Very good questions. Last year, I presented one paper in Trisakti University during the conference itself. I presented on the what are the hazards exposed by these Grab riders for sending food and all. So actually, they're exposed to heat, they're exposed to vibration, they're exposed to noise. If they're having noise interfering laws, nobody knows because nobody checked on them. So if they are registered under one organization, their at least their welfare be taken care of. If they have the noise interfering laws, they can claim compensation from Social Security Organization. Maybe more study need to be done. In Indonesia, I hope you can do studies among those taking care of the traffic. I don't know what you call that. They are actually exposed to a high level of risk, actually, Dr. Rubayat.
Yeah, you mean taking care of the traffic is this is not a police, yeah, not a formal police. But in here we call what is that? Polisi cepek atau parkir.
It is not the police, the one that informs workers.
Yeah, not the police. We can call polisi cepek. Or what is that? Tukang parkir.
Tukang parkir kadang-kadang kan.
That is very high risk on heat and then chemical hazard maybe from the
chemical hazard. To hydrocarbon. To benzene.
Okay, thank you for the question. And then we have a question from Dr. Rahma Sabila. Please, Dr. Rahma, unmute yourself.
Thank you, Dr. Rubayat. Thank you, Prof, for the material. I'm still curious about how big is the influence of body composition or body proportion or body size as a factor in occupational disease.
Sorry again, Dr. Rahma. The influence of?
Is the influence of body composition or body size as a
composition?
Factor? Yes. Body size or body composition as a factor in occupational disease.
You mean compensation, is it?
Occupational disease, body size.
Maybe overweight or obesity.
Maybe. Body size. If someone or if a worker are obese, how that is influence or how can they get occupational disease, Prof?
If they are in the office, I mean.
Yes.
Okay, all right. If I get the question correctly, Dr. Rahma, I'm very apology on that. You are asking about the impact of those working in the office, impact towards the occupational disease. Is it the question?
About the body weight, body weight. Maybe someone overweight or obesity.
Okay, all right. Body composition.
How much or how big for the future we have occupational disease or related disease.
Okay, all right. Very good question, Dr. Rahma. Non-communicable diseases. This is another important aspect under the occupational health. If you are a doctor for a company, for example, you are not only looking into occupational disease, you are not only looking into communicable disease, you also have to look into health and well-being of the workers. What I meant by well-being of the workers, we look into the non-communicable disease. Make sure workers didn't get hypertension, make sure workers did not get obese, the body composition, the fat composition, and all that. Okay, if you look directly into the non-communicable disease management at the workplace, this is what company usually look at because they think this is very important. Make sure workers didn't get hypertension, diabetes, stroke, and whatsoever, and obesity as well. So wellness program at the workplace, if you didn't institute that program at the workplace, when the workers getting obese, the body composition, the fat percentage is higher, they're at a higher risk of getting all the chronic diseases. That's the first point, right? Of course, if your fat percentage is high, you get hypercholesterolemia, this will lead to myocardial infarction or cerebrovascular accident or stroke. Right? We don't want our workers die have a premature death because of the heart attack or stroke itself. That's the first one. Second, in terms of the productivity of the workers, if the work require you to do a manual handling, require you to do a lot of movement, if you have a big body size, this will limit some of the movement, especially in the area whereby you need to work in a confined space. If you work as in the mines, for example, you need to enter some confined space. Body composition, body size plays a very important role. This is one of our fitness to work assessment. We look into the body size itself. Okay, so besides that, we want to make sure that our workers is always keep the cholesterol level at the lower level, so that we can reduce the risk of any other non-communicable disease. And those with stress, if you study psychosocial hazard as well, those with high level of fat, they have higher risk of those with stress and obese, they have higher risk of getting diabetes. For example, if because stress hormone is kept inside the fat cell itself, and those who are stressed, they can have their central obesity, the cortisol level higher, and they can get central obesity. And fat itself can keep higher level, lower level of insulin, so that you might get diabetes as well. So there's an association between stress and obesity, whereby it can lead to non-communicable disease development. So if you work in a stressful environment, and if you can't keep your fat level at the optimum level, it might increase your risk of getting a non-communicable disease as well.
Yeah. So can we say that such as diabetes as an occupational disease or occupational related disease, or just general disease, Prof, from the setting of the workers such as we discussed?
That's a very interesting question that required. Okay, all this while we say that diabetes is one of the disease among our workers. It is not occupational disease, it is not work-related disease. It's one of the disease, non-communicable disease among our workers. It can give an effect to our worker productivity. But yes, we can see some association there, relatedness there. If you are stressed, high stress hormone, high insulin, then you might overwork your pancreas, then this lead to diabetes, for example.
Yeah.
But the association, the causation is not clear yet.
Yeah.
So without this, we call in epidemiology, Bradford-Hill's criteria, the causation of the stress itself causing diabetes. Without that, we cannot confirm that this is an occupational disease. And then if you want to say it's work-related also, you have to see whether stress is really due to work or not, or is a domestic stress or traveling stress or other type of stress. That's why when we talk about psychosocial hazard, it's a bit difficult topic, whereby for compensation per se, we only at the moment accept post-traumatic stress disorders for compensation.
Yeah.
Even stress at the workplace also, we cannot confirm. It's quite difficult to confirm that the stress coming from the workplace. But of course, more study needs to be done.
Yeah. So we just say it is just a general disease, not
it's a general disease among our workers,
yeah.
But it might impact our productivity of the workers.
Yeah, because because I have some experience in the factory. Some of the factory, one of the patient, he had hypertension, and then 3 months ago he got an attack on cerebrovascular attack. We call it a stroke, and then the union of the worker thinking that this is must be because of the worker. Because of the workplace. So they think that it is the stroke and hypertension and cerebrovascular attack. It must be categorized as occupational disease. So the union push the management to have the patient for the compensation. So it is as for my role to explain to the worker union and then to the management that this is not occupational disease, because we know that one of the only one factor in the workplace that could lead to the hypertension and also stroke. So I have to stand between the management and the worker union. That is the challenging for me.
Yeah, very good experience, Dr. Rubaiyat.
Yeah,
That's the function of occupational health doctor, to stand between employer and employee. We are the link between these two, and we talk about science, we talk about evidence, right? Sometimes we tend to sway to support the employee, but sometimes we tend to sway towards supporting the employer. But we have to be based on the evidence-based practice, our medical knowledge itself.
Also regarding the COVID, Prof, they must be isolated now for 2 weeks, even until 1 month, because the PCR still positive. The worker union pushed the management to come on, this must be shortening the quarantine or the isolation. So they have to go back to work, and they know that the compensation is always regarding to the occupational disease or related disease. So I think the union worker is, we have to educate them, not only because of the money of the compensation, but also this is the rules, because the COVID-19 is the new disease. So we, all of us, must study together. We can, by experience from other factory. I think it is important important role for the occupational doctor. And for the student, don't be worried. If they graduate, as you mentioned before in the beginning, that occupational health doctor is very interesting. If we are not choosing other specialists.
Yeah, I agree with you totally, Dr. Rubaiyat. You know, if a surgeon going to the operation theater, do the test, do the procedure and all that, we not only sitting in our clinic, but we go to the factory to do the investigation. Our investigation is over there, and we need to really get involved in all this procedure as a good occupational health doctor.
And we have to move, we have to walk, we have to go up and go down of the stair. I think it's healthy for the doctor. because we have activity.
We move around.
Yes. Yeah. Okay, thank you, Dr. Rama, for the question. Maybe another question from the student. Maybe you can raise hand and unmute yourself. Muhammad Akbarul Ramadhani. Please unmute. Okay.
Thank you, Dr. Rubaiyat. And Assalamualaikum warahmatullahi wabarakatuh. Let me introduce myself. My name is Muhammad Akbarul Rahmanus Gunarto, from the student of University of Muhammadiyah Malang. Professor, I have asked you something about during this almost 2 years of COVID-19 pandemics. Most of the office workers were used to working from home. What else policies do we need to prepare to re-implement working from the office again? Thank you. Assalamualaikum warahmatullahi wabarakatuh.
Thank you very much. Waalaikumsalam. Very good, very important questions. Reopening of the office, of the workplace. What are the control measures that we need to apply? So this is the function of occupational health doctor, to advise the company what kind of control measures. Okay, yes, we are moving towards the transition towards the endemic. We might be opening our industry either 100%, 50%, or we can still apply hybrid working environment. But to open the workplace 100%, first we need to do the risk assessment. We need to make sure that the environment is safe in terms of the ventilation, in terms of workplace setting, all right? And we see whether it is important for us to go back to work first. If it is essential to be in the office, yes, by all means. But now there's a lot of company looking towards hybrid working environment. They can still function even though they are not in the office. So not necessarily endemic, everyone has to go to the office. Not necessarily now, because we are now coming into a new digital era. But then if we need essential to be in the office, by all means go, but control measures need to be applied. For Petronas, for example, we applied few control measures. For example, the first one, we still apply 50-50 kind of working arrangement. We have a working cohort. Group A go to this week and Group B go to another week. And every week, we do the self-test, make sure that self-test is conducted. Even though it is not stipulated by the government, you still have to conduct self-test. If you are positive, stay at home. Office environment, ventilation is in place, and spacing, we still encourage spacing, and mask is still mandatory to be worn, even though you are in the office. However, we didn't stop any physical event. If you want to have a physical meeting, if you want to have physical workshop, yes, you can continue with that. What most important is we have to maintain our surveillance. I just listened to one of the speakers from UK. They're mentioning about transition to pandemic. What important is our public health surveillance is still there. So if there is any breakthrough infection, close contact identified, the positive case being isolated, then it's good enough. As long as there's no outbreak, does not give impact towards the hospitalization and death numbers, then our company should be able to open safely. But please bear in mind, everyone need to understand about these control measures, and everyone need to be aware about the behavior, because some people might not be following all the instruction. So everyone need to be aware about all the control measures that we try to apply lah. And we need to have a strong surveillance system in the workplace. All are good questions. I like the questions coming from the student. Yeah.
Because as from the beginning, Dr. Ruby said that the material, the lecture material from the beginning, we already give it to the classroom, and then we also have a skills laboratorium. We are training about this. And then we still have around 8 minutes. Maybe I open one or two questions from the student. Okay, Widya Putra Adinugroho, please unmute yourself and ask your question.
Okay, thank you, Dr. Ubayat. Okay, excuse me, Professor, I want to asking about, is there any special policy that we can apply in the process of return to work for workers who have previously been diagnosed with COVID-19?
Sorry, again, I can't hear you, Vidya.
Repeat, please. What is? Can you repeat, Vidya? Repeat your question, please. Yeah, please unmute first and then just say it again.
Okay, Professor, I want to asking about, is there any special policy that we can apply in the process of return to work for workers who have previously been diagnosed with COVID-19?
Oh, it's about return to work from for the worker who get the COVID. Is there any policies?
Okay, yeah. Thank you very much, Vidya. Yes, in terms of case management, as I mentioned just now, those post-infected with COVID-19, of course, there's a special policy for them. First of all, when we said that everyone need to be tested before entering office. Last time was 2 weekly, now 1 week, every 1 week. For post-COVID, they might have a viral shedding, we call it viral shedding, whereby their test can be still positive. Okay, so we're giving an excuse for them, exemption for them from doing the weekly testing. They can still come to office after the procedure period without the weekly testing. Last time, okay, after you got COVID, usually released from the isolation, when you do the test can be still positive because of the so we allow them to be exempted. That's the first one. Second, for post-COVID, they can come, no problem. However, if they have a post-COVID symptom, or however, if they need certain type of follow-up, we have our special doctors who give the advice to them whether they need to do a follow-up with regards to post-COVID symptom or not. Because some patient with COVID, they might have some cognitive function problem. They might have their breathing might not be normal, okay? A bit shortness of breath and all. Their effort tolerance will be lower. So all these we need to support them by having a post-COVID rehabilitation follow-up to them. That's the second one in terms of medical. And last one, for booster vaccination. We already encourage all our workers to get their booster vaccination. However, for those with COVID infection and completed 2 doses, we give them an allowance until 60 days before they ask to take their booster. Okay, so the vaccine, the infection itself is considered as additional immunity to the 2 doses of vaccine that they have taken. So for those with COVID infection, they are given until 2 months before they can get their vaccination. So they can enter office even without the booster vaccination. So all that we need to tell it down according to government policy and also the company requirement. We know that they have additional natural immunity, so some adjustment can be done because of whatever evidence that we have at the moment. That's my answer, Vidya. Maybe Dr. Rubaiyat, you want to add on that?
I also have experience about the policy, whether we choose PCR tests or antigen tests. So until now, I know there is some factory, even the maybe multinational factory here in around Surabaya and Malang. Until now, they insist to choose the PCR test. As we know that PCR test still can be positive around 2 or 3 months, and for the worker, it is very non-productive. If we are working from home, maybe 2 or 3 months, and just until now they insist that PCR test still mandatory. We try to discuss about this, and then now there is adjustment. They just need to antigen test. So that is very from the economical, more economic, yeah. More economic, and then I mean the cheaper for the management to handle this, and they no need to wait until negative for the PCR test, because some cases, I found that maybe 2 or 3 months they from positive until negative. Yeah, instead of they have no sign and symptoms, and this is
you're correct, Dr. Rubaiyat. Because PCR, even though the CT value is 34, the cycle time value is 34, it is a viral shedding. It's an old infection, but it can still be positive, right?
Yeah.
That's why it depends on RTK. Usually the result positive showing that there is an active infection, and there's enough viral load to cause the positive result in RTK antigen.
So we need to adjust the policy, and that is one of our role as a occupational doctor to give explanation about this.
Exactly.
Yeah. Okay, maybe one question more. We just remaining time about two minutes. Muhammad Akmal Ramadan, please unmute yourself.
Okay, so thank you for the time, Dr. Rubaiyat, and thank you very much, Professor, for the excellent lecture. So my question is actually pretty basic. We all understand that since the pandemic, financial distress is a big deal, especially in the company. So that's why I'm wondering what wellness programs, which are cost-effectively we can do at the company to prevent the illness of COVID-19. Thank you very much.
All right, thank you very much, Akmal. Very clear and very important question as well. Like was asked by Dr. Rama on the importance of prevention of non-communicable disease. So it same goes to the question just now regards to what we can do in terms of wellness among our staff to make sure that our staff maintain their well-being during this pandemic itself. First, we understand those with comorbid, their severity of infection will be much more severe. Okay, those with hypertension, those with hypercholesterolemia, diabetes, they might have more severe infection if they contracted with COVID. So it's very much important for us to do health promotion, to promote healthy lifestyle so that they can prevent themselves from getting non-communicable disease. Then we can have a less impact on the pandemic itself. That's the first one. Second one, being working from home, having adjusted work environment, this might lead to inactive physical activity. So we have to promote walking, we have to promote physical activity among our staff to ensure that we can prevent all those NCD. Example that we have in my company, whereby we encourage everyone to join what we call as walk around the world. Okay, why we call walk around the world, meaning for each of the state country that has our Petronas branch. For example, last month we are walking in Turkmenistan. In Turkmenistan, you have to walk for 200,000 step to visit all the city there. So it's a digital visitation. So if you walk for 20,000, then you can move to another state, another town, another town. At the same time, you show how the town look like and all that. So this encourage our workers to move. Okay, after you complete Turkmenistan, we can fly to Brazil and we can fly to Spain. So now they have opened three countries. So now I'm in Brazil now. I'm walking. Every time I walk, I visited the town in that country. So it's kind of interesting program. Encourage people to walk and increase step, and at the same time increase well-being, increase wellness, and prevent from non-communicable disease. So this kind of program is very much important if you are the health advisor or occupational doctor for a company, actually.
Okay, but before we encourage the worker to work, we have to give example, yeah, Prof. Give example as a doctor, as an occupational doctor, we have to give example so that the worker believe that this program will be benefit for them. Yeah. Okay, because the time is up, I want to once again say thank you for your very nice lecture, very nice discussion, and then we just giving the student additional information about from your experience in Petronas, especially. That is very interesting for us. And then we hope this lecture is just the beginning of our cooperation and our collaboration between University of the Malaya and Faculty of Medicine, Universitas Muhammadiyah Malang. We hope that in the future we could working together in the field of education, such as research and publication, guest lecture, and then student exchange, and maybe lecture exchange on occupational health and so on. Before I close this session, maybe you have some take-home message for the students during the pandemic and after pandemic. In terms of our fields, that is occupational health, maybe you have some take-home message for us, for the student, so that they can understand more about occupational disease, occupational related disease, or maybe general disease. Please.
Very much, Dr. Bayat. To all the students here, you're going to be our future doctors, and we hope to all our future doctors here to be more resilient. You as a student, you have faced a lot of challenges during your study period now, and with those challenges, this will make you more resilient, stronger in facing the actual working environment later on. And with this experience during your study period, of course, I think, of course, I'm confident you'll become the best doctor, a better practitioner outside there after this. And please remember, prevention is very important, and public health. You can imagine without public health system at workplace, how we can manage this pandemic properly. So public health is very important, and of course, occupational health, one of the branch under the public health. Whenever you are working, you see patient, please remember their cause of the disease itself, whether it's coming from the workplace or not. And not only treat the disease, try to treat the cause of the disease itself. Thank you very much.
Okay, thank you, Prof. Marzuki. I hope we will see again in the next Zoom meeting, or maybe you can come to Indonesia, you can come to Malang, and then we can join some several activity in here. Okay, because the time is up, I am as a moderator, just giving once again thank you, and so sorry if is there any mistake from me. So I give the Zoom meeting for the MC, Dr. Rahma, before we go to taking picture together, Prof. Okay, so please still stand by in here before we go to the taking picture together, Prof. Thank you. I close this session. Wabillahi taufiq wal hidayah. Wassalamualaikum warahmatullahi wabarakatuh.
Waalaikumsalam warahmatullahi wabarakatuh. Terima kasih Dr. Ubaya, terima kasih Prof. Marzuki. Oke, selanjutnya kita akan foto bersama. Dimohon untuk Bapak Ibu dosen dan adik-adik mahasiswa 2021 bisa mengaktifkan kameranya, menyalakan kameranya. Oke, kita akan foto bersama, akan dipandu. Sudah siap? Itu dari tim IT sudah siap? Oke. Saya hitung sampai 3, 1, 2, 3. Oke, untuk layar yang kedua, 1, 2, 3. Kemudian untuk yang berikutnya, 1, 2, 3. Yang layar berikutnya, 1, 2, 3. Oke. Layar selanjutnya, 1, 2, 3. Sudah Mas Zainal? Oke, dengan berakhirnya sesi diskusi hari ini, maka berakhir juga acara pada hari ini. Semoga apa yang telah kita dapatkan materi dari Prof. Marzuki bisa bermanfaat untuk kita semua. Sebelum kita menutup acara pada hari ini, marilah kita membaca hamdalah bersama-sama. Alhamdulillahirabbil alamin. Saya Dr. Rahma Sabila, selaku Master of Ceremony pada hari ini. Mohon maaf apabila terdapat kekurangan atau salah kata. Akhirul kata, wabillahi taufiq wal hidayah. Wassalamualaikum warahmatullahi wabarakatuh.
Waalaikumsalam warahmatullahi wabarakatuh. Thank you, Prof. Marzuki. Stay safe, stay healthy.
Thank you, Dr. Ubayat.
Yeah, thank you.
Assalamualaikum.
Waalaikumsalam.
Assalamualaikum.
Jangan lupa isi presensi ya, Dik. Isi